Hello and welcome everyone. Today's topic is diagnosis and management of autoimmune diseases in ICU. Autoimmune diseases are heterogeneous inflammatory disorders with a spectrum ranging from organ-specific multisystemic disorders leading to multi-organ failure. The prevalence is 5 to 10% in general population. The types are connective tissue disorders like SLE, systemic scleroderma, Sjogren syndrome, inflammatory muscle diseases, rheumatoid arthritis, and overlap syndromes. Vasculitis, various forms of vasculitis are there, and other conditions like sarcoidosis and unclassified pathogenesis like Still's disease. Now, the common features are they present with a varied clinical symptoms involving multi organs, leading to possible incorrect and delay in the diagnosis. They usually have autoantibody production. Frequent management is immunosuppression, and improvement in survival rates have been noted over the last 2 decades due to better understanding of the disease mechanisms, advanced diagnostic tools, and targeted therapies. ICU admissions, despite the improvement in the survival rates, do occur. Up to 10% of the patients still require ICU due to disease flare ups, infections because of the immunosuppression therapy, or acute organ failures because of the disease process. Now, the challenge that the intensivists face is because of the need to early identify the disease flare. Now, detecting the disease flare-ups early in case of unexplained or unusual clinical presentations becomes very important. The goal is to prevent in-organ failure and reduce the mortality. Now, immunosuppressive treatment alongside life-sustaining therapies is another challenge because it provides effective immunosuppressive treatment, and we may also be requiring to give other antibiotics like for infection processes. Now, how to manage the adverse effects of the immune suppression therapy is another challenge. The next challenge is to identify and manage the side effects of these immunosuppressive therapies, especially in the background of an infection. The side effects are often difficult to distinguish from exacerbation of underlying autoimmune disease, and the data that is coming from the ICU is also limited. So the intensivist doesn't have much of an evidence-based guideline for him. So informed decisions with limited data specifically regarding the autoimmune disease process is the major challenge. Now, 5 clinical situations that every intensivist should be aware of. These are scleroderma crisis. The life-threatening complication in scleroderma requires ICU admission because of the non-scleroderma related causes, that is around 71%, or respiratory complications. Now, scleroderma renal crisis occurs up to 2.4% cases of these patients, and the survival rate in 5 years is around 50 to 70%. Now, the symptoms is malignant hypertension, oliguric acute kidney injury, left ventricular insufficiency, hypertensive encephalopathy. Now, the risk factors are more frequent in patients with corticosteroids triggered by nephrotoxic drugs or volume depletion. The diagnostic is microangiopathic hemolytic anemia in 43% of the cases, anti-RNA polymerase 3 antibody in one-third of the patients. Treatment is aggressive blood pressure control with ACE inhibitors and other hypertensives, the requirement of dialysis, and possible renal transplant. Scleroderma cardiac crisis. This is uncommon but life-threatening condition with which is recent onset vascular phenotype with acute ventricular dysfunction is the presentation. The prognosis is 44% alive at 6 months. The next condition is pulmonary renal syndrome. This is a diffuse alveolar hemorrhage with necrotizing glomerulonephritis. It is ANCA vasculitis in 70% of the cases, anti-GBM in 20% of the cases. Acute respiratory failure could also occur in 50% of the cases requiring mechanical ventilatory support. The diagnosis, the problem is with differentiating it from sepsis, bronchoscopy to exclude infection, identify diffuse alveolar hemorrhage, histological diagnosis with percutaneous renal biopsy, lung biopsy are alternatives, but much more riskier options in critically ill patients. The next is acute interstitial lung disease. This is seen mostly in connective tissue related ILDs. The prevalence is 15% of the all patients with connective tissue disorders. Presentation is non-specific interstitial pneumonia, most common, but usually interstitial pneumonia can also be seen. Now, HRCT, bronchoalveolar lavage, serology for autoantibody, lung biopsy are done, but biopsy are usually not required. Prognosis is rapidly progressive form leads to ARDS, which has poor outcome, more than 50% mortality, especially in the background of scleroderma or AMDA5 syndromes. The treatment is steroids except in scleroderma. Immunosuppressive therapy like cyclophosphamide or mycophenolate mofetil, and in selected cases ECMO or transplant can also be done. Acute severe cytopenias. Now this is a common presentation of autoimmune disorders, especially SLE. The types are autoimmune hemolytic anemia, idiopathic thrombocytopenic purpura, thrombotic microangiopathies. Diagnosis is peripheral smear to look for cystocyte, bone marrow aspirate, looking for pancytopenia. Triggering factors are TTP, SRC, CAPS. Now the complications are hemophagocytic lymphohistiocytosis or bone marrow necrosis. The treatment and prognosis is the treatment has to be individualized based on the specific cause, and HLH has very high mortality up to 70% in the ICU. Now last is the CAPS, that is catastrophic antiphospholipid syndrome. This is triggered by infection, surgery or medication involving antiphospholipid antibodies. It is affected organs are kidney, lungs, heart, CNS, skin, liver and GI tract. The diagnosis is based on criteria for definitive and probable CAPS, that is differentiating from the other thrombotic disorders. Mortality rate is high, around 30% being fatal in a particular study. The management challenges are the need for further studies to evaluate the CAPS criteria that is done for diagnosis, determine appropriate management strategy, because most of the treatment is still in experimental stages, not really clear. Now, next is how to recognize an autoimmune disease in critically ill patients. Now, the prevalence of ICU admissions due to autoimmune diseases is one-third of the ICU admissions are due to disease flare-ups, either from existing autoimmune disorders or inaugural manifestation of a new disorder. The clinical signs of severe autoimmune disorders are acute respiratory failure, acute kidney injury, neurological disorders, and cardiovascular complications. History is a very important factor because you will have a chronic history with non-specific symptoms from sometimes ranging even in months. The common ones being fatigue, fever, headache, unintended weight loss, polymyalgia, and polyarthralgia. Rare occurrences are acute cytopenia, mainly anemia and thrombocytopenia. Now, SLE and other connective tissue disorders have their specific presentation. They can affect all organs. Now, the leading cause of ICU admission is acute respiratory failure. Suggested signs are rapid progressive interstitial lung disease, respiratory muscle weakness in dermatopolymyositis, shrinking lung syndrome in SLE. Now, renal involvement is glomerulonephritis, vessel thrombosis, thrombotic microangiopathy. Other complications are cardiogenic shock in myocarditis, CNS disorders, especially in the SLE patients. Now, systemic vasculitis. They can present with inflammation of the blood vessels with clinical presentation varying based on the vessel size. Now, small vessel vasculitis, they present with ANCA vasculitis and immune complex mediated vasculitis. The common presentation here being acute respiratory failure due to the alveolar hemorrhage, sometimes linked to rapidly progressive glomerulonephritis as a pulmonorenal syndrome. Now, pulmonary manifestation are pulmonary nodules in granulomatosis with polyangiitis, severe asthma in eosinophilic granulomatosis with polyangiitis. Renal involvement is frequent with the ankylosing, and renal infarctions are common with polyarthritis nodosa and Takayasu's arteritis. Cardiovascular and GI symptoms are common with the vasculitis. Neurological neurological involvement are also common, like cerebral ischemia, mononeuritis multiplex in polyarthralgia nodosa and ANCA vasculitis, meningitis. parenchymal brain lesions in Behçet's disease. The other is systemic diseases like sarcoidosis. They're rarely diagnosed in the ICU. They can present with cardiac and neurosarcoidosis, which can be life threatening. Now, adult onset still disease presents with high spiking fever, skin rashes, arthralgia, the DD being unexplained myocarditis or severe macrophage activation syndrome. Now, these are some of the symptoms which can be seen. So, if you come from top down, you can in the brain you can find stroke, seizures, aseptic meningitis, delirium. In the lung, ILD, pleural effusion, diffuse alveolar hemorrhage, kidney, glomerulonephritis, thrombosis, scleroderma renal crisis, tubulointestinal nephritis, skin manifestations, libido reticularis, hematological like anemia, hemolysis, thrombocytopenia, coagulation abnormalities, joint inflammations, muscle inflammations, Raynaud syndrome, you can see in the skin, heart involvement, cardiogenic shock, tamponade, endocarditis, embolism. You can have photosensitivity, alopecia, and skin rashes. Now, these are some of the disease which affect the larger vessels. In this, you will see strokes, meningitis, ENT symptoms, aortic dissections, coronary artery diseases, cardiogenic shock, bleedings in the GI tract, ischemia of the GI tract, hepatic vein thrombosis, multiple skin involvements, renal involvements, and lung involvements. Now, how to do our diagnostic workup? The most important is history and examination. This is essential to make an initial diagnosis. Consider the epidemiological factors like the ethnicity, age, and sex. That could be a very important factor in determining which group of disease we may be dealing with. Like in women, SLE and scleroderma are common, and in men, as you saw, ankylosing is common. Clinical symptoms and examination. The symptoms are severe sinusitis, myalgia, polyarthralgia, pericarditis, mononeuritis, skin and eye involvements with ulcers and photosensitivity, blood tests looking for proteinuria, hematuria, renal cast. The purpose is to suspect an autoimmune disease and its extent. The clinical workup guided by the clinical syndrome to confirm the diagnosis and exclude other etiologies. Based on the international societies, you will do the diagnostic criterias. The next is autoantibody detections. Antibodies can be present without autoimmune disease and vice versa also. Now, histologically can assist in establishing diagnosis and evaluating prognosis. Common biopsy sites are skin, kidney, muscles, sural nerve, temporal artery, salivary gland. Consideration in ICU patient should be done for the diagnostic criteria because it may not be so straightforward in critically ill ICU patients. In eye specifically, you can find symptoms like the helicotrope rash, the eye dryness, ptosis, uveitis, and episcleritis. They may be associated with various disorders. In skin, you can have splinter hemorrhages, racked cuticles and nail fold redness, Gotten papules, Raynaud syndrome, digital necrosis, hyperpigmentation, small joint arthralgia, scleroderma hand, and mechanical hand. So again, various diseases associated with specific presentations. Now, once you have done a diagnosis, how to manage these patients, especially the flare-ups. The general principle is to go for evidence-based medicine because practice can differ across the centers. So prompt ICU admission and collaboration with the specialists is very crucial. Immunosuppressive therapy is the cornerstone because this is the therapy which will reduce the disease process. Timely treatment is very important because without that the disease will continue to flare. Specific approaches. These are for connective tissue disorders, high dose glucocorticoids combined with cytotoxic agents like cyclophosphamide. For ankylosing, use the 5-factor score for treatment decision. Cyclophosphamide as a common cytotoxic agent, IVIG in severe infections, plasmapheresis for rapid progressive glomerulonephritis and pulmonary hemorrhage. Giant cell arteritis, steroids especially with neurological and ophthalmological symptoms. SLE, steroids with cyclophosphamide or mycophenolate mofetil. HCQ role is in acute settings is unclear. Severe myositis, IVIG in addition to steroids. Autoimmune cytopenias, steroids, IVIG, anti-CD20 antibody like rituximab, splenectomy in refractory cases. Catastrophic antiphospholipid syndrome, anticoagulation, high-dose methylpred, plasmapheresis, IVIG, rituximab. Now maintenance therapy. To avoid relapse and spare steroids, maintenance therapy should be started with methotrexate, azathioprine, and mycophenolate. The treatments are significant sources of morbidity and mortality. This should be kept in mind. The research is lacking in targeting key mechanisms of the connective tissue or vasculitis. With emerging therapeutic advances, we are becoming more specific. However, the exact role in critically ill patients of these new therapies remain to be defined. Now, drug-related complications. Complications for older drugs like pulmonary toxicity with methotrexate, adrenal crisis with steroid withdrawal. This must be kept in mind. In new drugs, you have to be knowing the specific complications that can develop with them. Risk of infection should be kept in mind, especially the common bacterial infections like pneumonia, bloodstream infection, especially with listeria. Tuberculosis and its reactivation, especially in Indian setup, should be kept in mind, especially in patients with anti-TNF drugs. Now, pneumocystis pneumonia, again a common thing, especially should be kept in mind for steroid more than 15 milligram per kg dosage who are getting, or cyclophosphamide or rituximab. Meningococcal infection, important in eculizumab treatment. Varicella zoster, higher rate of reactivation, especially if it is disseminated, it can also increase the mortality. Hepatitis B reactivation is also very common, so screening and prophylaxis is recommended. Opportunistic infections like strongyloides, other infections like nocardia, histoplasmosis, aspergillosis, CMP reactivation must be kept in mind. In strongyloides, hyperinfection syndrome and disseminated infection is common, so prophylaxis with ivermectin should be kept in mind. Preventive measures like proactive screening for infections after starting the immunosuppressive therapy, empirical prophylaxis in high-risk patient even without confirmed exposure is important. Next, looking at neurological autoimmune emergencies that you can face. These clinical spectrum ranges from varied symptoms based on the lesion and the extent. Here you will find altered sensoriums, seizures, tetraparesis, dysphagia, autoimmune dysregulation, and raised ICPs. Now, the types are primarily neurological like myasthenia gravis, autoimmune neuritis, encephalitis, systemic autoimmune because of other factors, or peripheral nervous involvement, as you can see with Sjogren syndrome, systemic vasculitis, and sarcoidosis. Now, the CNS involvement in SLE is seen with demyelinating disease, meningitis, seizures, psychosis, with Sjogren syndrome, brain lesions, transverse myelitis, meningitis, ankylosing, you will have cerebral vessel inflammation, granulomas, meningitis, and strokes. In Behçet syndrome, you will find parenchymal meningoencephalitis, non-parenchymal central venous sinus thrombosis. Now, sarcoidosis and IgG4 related will also present with encephalitis and seizures. Treatment approaches is predominantly steroids and with cyclophosphamide, rituximab, or methotrexate. TNF alpha antagonist can be used in Behçet and sarcoidosis. Plasmapheresis and IVIG for severe presentations. The DD and workup is very important. Exclude the other causes like vascular, infectious, and metabolic. MRI in CNS involvement, digital subtraction angiography for vasculitis. EMG for peripheral nerve lesions, and plexus MRI for autoimmune neuritis. Lumbar puncture with CSF analysis is very important. Now, these are the various manifestations that you can find. You can have systemic manifestation or peripheral. These are the autoimmune disorders which can result in these manifestations. Next is cardiovascular emergencies. What cardiovascular emergencies you can find? You can find two primary lesions, that is vascular occlusions resulting in infarcts and ischemias, or myocarditis, aneurysms, vasculitis, pericarditis, which directly affect the cardiac function. So connective tissue disorders like the pericardial and myocardial involvement is seen in 50% of the cases in SLE. And myocarditis prevalence in SLE and myositis leads to cardiogenic shock at times. Scleroderma can lead to myocardial fibrosis, cardiac failure, conduction defects, and arrhythmias. Valvular diseases are rare but can be seen with Libman sac endocarditis in SLE. Now, antiphospholipid syndrome affects any part of the vascular system, resulting in thrombosis or immune mediated injury. Typical presentation is thrombosis in unusual sites, not atherosclerotic thrombosis. Pulmonary hypertension common in scleroderma and APS with poor prognosis. Vasculitis, cardiac failure is a major factor because of the myocarditis result of the EGPA, GPA or coronary disease in giant cell arteritis, Kawasaki disease, polyarteritis nodosa. Takayasu disease and giant cell arteritis are also common, resulting in severe aortic dissections, valvular regurgitations, and end organ ischemia. In Behçet disease, you have mainly venous pathology, thrombotic events, or cardiac involvement in terms of endocarditis or thrombosis. Now, major cause of morbidity and mortality is seen here because of the high incidence in these patients, and especially SLE and scleroderma have very high cardiovascular risk. The contributing factors are vascular involvement, endothelial dysfunction, chronic inflammation, and medication side effects. So, clinical vigilance is very important. High index of suspicion is required for patients with known autoimmune diseases presenting with cardiovascular disorders. Now, what is the prognosis? Now, prognosis and mortality remains very high, but exact data is mostly coming from retrospective studies. So, prognosis is based on the severity scores and the organ failures and the patient's frailty. ICU mortality rates vary from 50 to 60%. Higher mortality is associated if there is infection and delayed initiation of specific therapy. Myositis and scleroderma, particularly advanced lung disease and pulmonary artery hypertension, have poor outcomes. There are many unanswered and work to be done in research. That is a need for detailed clinical picture in critically ill to guide a diagnostic workup. ARDS mimickers in the connective tissue disorders and vasculitis need more attention. Scarce data on renal involvement in AKI due to autoimmune diseases. Importance of large prospective multi-center studies to assess prevalence, identify red flag syndromes, and standardize diagnosis and management. Challenges in treatment and management. Limited data dedicated to critically ill patients. Recent changes in management such as vasculitis highlight these changes. Controversy and uncertainty in treatments, particularly in severe cases. Rarity of disorders and need for disease-specific assessment make individual randomization difficult. Potential for multi-center and multinational registers and clinical trial to assess involvement and treatment options. Underlying treatment side effects are also important. The need for research on side effects, especially of the new therapies, concern of rapid change in exposure to risk of landscape and intensive its ability to identify these risks, proposal for a dedicated register to document the treatment consequences. So overall, to summarize, how do you approach and manage a patient of autoimmune disorder coming to the ICU? Because many of them may not be coming with a pre-diagnosis. So if you find atypical or unexplained organ failures, like say a pneumonia with anemia, AKI without any recognized risk factors, or no response to empirical therapy, please have a doubt that the patient may have something else other than the specific presentation with which they have come, and look for systemic involvements. If there are systemic involvements, then please actively look for autoimmune disorders. In this, you have to look for the major three factors, that is, look at the clinical presentation again, the family history, the personal history, the ethnicity, the medications they are taking. Do a much more detailed clinical examination. Look at the signs, especially the skin and the eye signs, nails, everything can have a suggestive manifestation. You can do blood tests to find out the autoantibodies and other factors. Scans are required. Immunological workup is very important. Now, additional investigations like bone marrow biopsy, bronchoalveolar lavage can also help in diagnosis. Biopsies can also be done. Now, all of these help us in making a differential diagnosis and finding out that what could be the possible disease. But while doing this, also keep in mind that factors like malignancy, infections, drug abuse, endocarditis, which can also have these type of manifestations. Now confirm that there is a flare up. Once you have confirmed, do a multi team approach, find out the chronology of the symptoms, find out the inflammatory response, how much is the flare up, check your symptoms based on the international criteria, finally make a consensus diagnosis and go ahead with the management. Thank you for your patience, and I hope this video was helpful. If you like our videos, then do subscribe to our channel. Thank you.